Okay, so I hope you got a lot out of those videos. Let's move on now and finish up this program with a couple more conditions around the knee, and then we'll just have enough time to consider very briefly the tarsal tunnel syndrome at the ankle. And as we're approaching the 6-hour mark on this program, we won't have time to demonstrate the physical examination maneuvers for the remainder of this material, but I will, however, go into a full description of the physical examination maneuvers, and perhaps we can catch up on those videotapings and demonstrations, live demonstrations on another future program. So let's talk about the ligaments of the knee and the conditions associated with chondromalacia patella of the knee. The AMA guides in Table 1733 do provide for permanent impairment due to residual instability of the knee due to laxity of both the cruciate ligaments and then also the medial and lateral collateral ligaments. So reading directly from the AMA guides, and this is Table 1733, permanent impairment related to cruciate or collateral ligament laxity qualifies for permanent impairment of 3, 7, and 10% depending upon the degree of residual laxity, ranging from mild laxity at 3%, moderate laxity at 7%, and severe laxity qualifying for 10% whole person impairment. And that's due to laxity of either the cruciate ligaments or the collateral ligaments. Now, the AMA guides also provide for permanent impairment due to residual instability due to cruciate and collateral ligament laxity, providing for 10% whole person impairment in the event of moderate laxity and 15% whole person impairment in the case of severe laxity. And remember, with the cruciate ligaments, we have an anterior and a posterior cruciate ligament. Those are intra-articular ligaments that do pierce the joint capsule and are bathed in synovial fluid, while the collateral ligaments include the medial and lateral collateral ligaments. Those are extra-articular ligaments on the outside of the articular capsule. And when it comes to injury of the ligaments around the knee, I'm sure you're all familiar with the injury that we refer to as the unhappy triad. It's a common sports injury that involves a valgus stress to the planted foot. And I actually just saw one of those occur, I think it was 2 weeks ago in a NFL football game. It was a playoff football game, and it was a goal line stand, and one of the linemen had his foot planted and had someone run into the side of his knee and gave him a valgus stress, and down he went, only to be taken off the field by the stretcher. Taken off the field by stretcher. Or they have those golf carts nowadays. Well, anyway, with the unhappy triad injury, that involves injury to 3 structures. That's why they call it the triad. It involves injury to the medial collateral ligament, the medial meniscus, and then also the anterior cruciate ligament. So that's an example of a type of injury that could cause ligamentous laxity to both the cruciate and collateral ligaments, thereby qualifying for the higher levels of permanent impairment. Isolated injury to either the cruciate or the collateral ligaments qualifies for lower level of permanent impairment. So let's consider some of the injury conditions associated with the medial collateral ligament. Now, with regards to the medial collateral ligament is frequently injured with trauma to the lateral side of the knee or a fall, both of which have in common that they produce a valgus moment. Valgus moment is a force directed through the knee from lateral to medial, causing an opening or a gappening on the medial side of the knee joint. Many times this valgus moment involves a twisting injury, and frequently the patient or the athlete or the injured worker will report that at the time of the injury they felt or heard a pop or felt or heard a snap occur in the knee as one or more of those structures gave way. Now, typically the symptoms of medial collateral ligament injury include pain, pain located at the medial knee, pain that becomes worse with weight bearing. There may or may not be a joint effusion present, and the examinee will report that frequently it feels like their knee is going to give way or going to buckle on them, and they may actually even report a history of the knee buckling or giving way. So let's talk about the anatomy of the medial collateral ligament here. And for those of you that have your handout materials with you, and the rest of you that are watching the PowerPoint presentation, we have here the side view from the medial aspect of the knee. We have a diagram here that shows the medial collateral ligament, and I'll just highlight that with my laser pointer. It's right here. This is the medial collateral ligament. Okay, so let's talk about it. The medial collateral ligament has two layers. There's a superficial and a deep medial collateral ligament. Now, what we're seeing right here is the superficial aspect of the medial collateral ligament. We'll get to the deep portion of it in just a moment. Now, the superficial medial collateral ligament has a proximal attachment at the posterior aspect of the medial femoral condyle. It's just a couple of millimeters proximal and about 5 millimeters posterior to the medial condyle. So here is the medial condyle. We go a couple of millimeters proximal and a couple of millimeters posterior, and we see the proximal attachment here just above the medial femoral condyle on the posterior aspect. The distal attachment attaches at the metaphyseal region of the tibia, about 4 to 5 centimeters distal to the joint. Here's the bottom of the joint right here. Here's the tibial plateau. So we drop down about 4 to 5 centimeters distal, and we see the attachment down here on the tibia. The distal attachment lies just beneath the pes anserinus. Recall that the pes anserinus is the conjoined tendons of three muscles, the sartorius, the gracilis, and the semitendinosus. And I'm sure you remember back to Anatomy 101, the mnemonic SGT-FOT, to remember both the muscles that make up the pes anserinus and then the innervation of those individual muscles. So it's SGT-FOT. SGT is sartorius, gracilis, semitendinosus. FOT is femoral, obturator, and tibial nerve innervations, respectively, of those muscles. Okay, so there's our proximal and distal attachments. Then the superficial excuse me, medial collateral ligament can be divided into anterior and posterior portions. And I'll outline those here. Here's the anterior portion, and then here is the smaller posterior band of the MCL. The anterior fibers appear to tighten with the knee in approximately 70 to 105 degrees of knee flexion. And these posterior fibers, also known sometimes in some anatomy textbooks as the posterior oblique ligament here. Now, the function of the superficial band of the medial collateral ligament is to provide restraint to valgus stress. And there are other structures that contribute to valgus restraint in addition to the medial collateral ligament. But the medial collateral ligament provides the bulk of the medial restraint. Some references quote that 60 to 70% of the restraining force is resisted by the medial collateral ligament. And this range of restraint can vary based upon the particular angle of flexion that the knee is in. So, for example, at 25 degrees of knee flexion, the medial collateral ligament provides about 78% of the support to valgus stress, whereas at only 5 degrees of knee flexion, other structures contribute to valgus resistance. And here, at 5 degrees of flexion, the medial collateral ligament contributes only 57% of the support against valgus stress. And this gives us our basis for our testing of the medial collateral ligament. When we test the medial collateral ligament, we want to test it in a position that allows us to, as much as possible, to isolate the medial collateral ligament. And that's going to be somewhere around the position of 25 degrees of knee flexion, because in that position some of the other structures that contribute to valgus resistance become slack, and that allows us to more closely isolate the specific function of the medial collateral ligament. Okay, then if we peel away the superficial aspect of the medial collateral ligament, we're left then with the deep medial collateral ligament, as outlined right here. And it's the deep portion of the medial collateral ligament that attaches to the medial meniscus. And it attaches to the medial meniscus in two distinct and separate bands. So, first of all, the deep medial collateral ligament is separated from the superficial medial collateral ligament by a bursa, a synovial sac, and we talked about those in relation to the hip. Well, here we go again in the knee, and the knee is famous for many bursa. I've seen references that cite as many as 11 to 13 separate and distinct bursae in and around the knee. Well, here's one of them. The medial collateral ligament bursa would overlie the deep band of the fibers of the medial collateral ligament between the deep and superficial layers to reduce friction between those two layers as the knee goes through range of motion of flexion and extension. Now, the deep medial collateral ligament is divided into two bands. We have the meniscofemoral band here, from the meniscus up to its femoral attachment, and then we have the meniscotibial band from the medial meniscus down to its attachment on to the tibia. Now, this deep medial collateral ligament inserts directly into the edge of the tibial plateau and the medial meniscus, and it firmly attaches to the medial meniscus, but it does not provide significant resistance to valgus force. That is the job primarily of the superficial aspect of the medial collateral ligament. However, it's this deep component of the medial collateral ligament that's involved with injury that we referred to earlier, known as the unhappy triad. And it's because of its connection to the medial meniscus that a severe and deep injury to the medial collateral ligament will involve and will injure the medial meniscus. So here's an X-ray diagram, here's an X-ray exposure of the knee, and this is a stress view of the knee that shows injury to the medial collateral ligament. And we know that there's injury to the medial collateral ligament because the medial joint space here is widened with a stress applied in a valgus direction from lateral to medial. And that forms the basis for our physical examination testing of the medial collateral ligament. It involves the application of a valgus stress to the knee. Now, in physical exam, you're going to find tenderness to palpation of the medial side of the knee, extending from the medial femoral condyle to the proximal tibia, right down in the region of the pes anserine. In the acute setting, there may be ecchymosis. There may be ecchymosis. It may be tissue extravasation of blood. We would call that bruising. There may or may not be an effusion present. Certainly in an acute setting, there may also be effusion in the chronic case of chronic instability due to medial collateral ligament injury. Now, pathognomonic for this condition is pain, meaning medial knee pain, elicited when a valgus stress is applied to the knee. And you want to apply this valgus stress to the knee with the knee in 20 to 30 degrees of flexion. And you can perform your medial collateral ligament testing in a variety of angles of knee flexion. And some doctors do it with the knee in complete extension, and then work their way up through various ranges of motion, assessing for the reproduction of symptoms, and then also assessing for medial knee laxity throughout various ranges of motion. Now, remember, whenever testing the extremities, always compare bilaterally, because what may appear to be a lax joint may be normal for your particular examinee, and you could confirm that by testing the opposite uninvolved lower extremity. Now, let's go over some typical findings in the event of varying degrees of laxity of the knee due to medial collateral ligament injury. Remember that the AMA Guides provides permanent impairment for mild, moderate, and severe laxity. So, what kind of physical exam findings would we see in each of these circumstances? Well, with mild laxity, we're going to see medial knee tenderness. There will be minimal swelling, minimal ecchymosis at most, and no medial gapping when valgus stress is applied to the knee in slight flexion. In other words, physical examination maneuvers are not able to reproduce significant medial knee laxity. However, typical physical exam signs consistent with injury to the medial collateral ligament are present, and those would include tenderness to palpation. Joint swelling would obviously be a positive objective finding, as would local tissue ecchymosis. With moderate laxity, now we're going to start seeing more pain, more tenderness to palpation, and this can be localized to either the tibial or the femoral insertion of the medial collateral ligament, or tenderness might be located in the mid-substance of the ligament in either the anterior or the posterior band, anywhere along the course of its fibers. And with moderate laxity, we're going to start seeing now some medial knee gapping with the application of valgus stress. And gapping between 5 and 10 millimeters, medial gapping qualifies as moderate laxity. Now, with severe laxity, we usually won't see cases of severe laxity unless there's been a complete rupture of the medial collateral ligament. With mild laxity and moderate laxity, we have some disruption of fibers. However, some fibers of the ligament remain preserved. Remember that the ligament is dense, regular connective tissue, dense, regular fibrous connective tissue, largely, nearly 100% organized collagen fibers. Well, with complete rupture of these collagen fibers, now we're going to see significant medial joint gapping greater than 10 millimeters. And there'll be tenderness to palpation and generally effusion on the medial aspect of the knee joint. In a workers' compensation setting, injury to the medial collateral ligament frequently shows up on X-ray studies as a readily identifiable calcification of the medial collateral ligament. So you'll see this on the medial aspect of the knee, and this is known as the Pellegrini Stieda lesion. Now, the Pellegrini Stieda lesion is a calcification at the medial distal femur at the origin of the medial collateral ligament, usually indicative of chronic injury that has undergone some healing and subsequent calcification. Now, this X-ray shows the Pellegrini Stieda calcification at the proximal attachment of the medial collateral ligament up above the medial femoral condyle. Question I have for you is, if the medial collateral ligament was sprained at its distal attachment, could we see a Pellegrini Stieda lesion adjacent to the tibia? And the answer is yes. And if the medial collateral ligament was sprained with some tearing and rupture of some fibers along the mid-substance of the ligament, is it possible that we could see a Pellegrini Stieda lesion along the mid-aspect of the joint adjacent to both the femur and the tibia? And the answer is yes. In fact, the Pellegrini Stieda lesion can traverse the entirety of the length of the medial collateral ligament, and I have seen those large lesions spanning the entirety of the length of the medial collateral ligament. Now, usually the Pellegrini Stieda lesion is indicative of an old or chronic medial collateral ligament injury that may or may not be associated with medial knee pain symptoms currently. Typically, it's found as a coincidental finding on diagnostic studies, but it may be related to knee pain syndromes for which you are examining your injured worker. So that's your job as the examining doctor, is to correlate any diagnostic study findings with the clinical history and the physical examination findings of your own examination. But be on the lookout for Pellegrini Stieda lesions found on routine views, anterior to posterior views of the knee. Now, we won't have time to demonstrate this, but I want to describe the valgus stress testing for assessing the medial collateral ligament. This can be done either sitting or supine. Typically, it's done supine and with the involved limb in a relaxed position. And you're going to want to perform valgus stress testing in a variety of test positions, beginning first in full extension and then moving through various degrees of knee flexion. And this allows testing of both the primary and the secondary restraints against valgus stress, that is. And as we said earlier, with the knee in full extension, the role of the medial collateral ligament in resisting valgus stress is reduced, but is still involved. Still restrains 57% of the valgus load, with increasing percentage of restraint of the valgus load as the knee goes through increasing degrees of knee flexion. And that is because in the position of flexion, the posterior capsule is relaxed. This allows for isolated testing of the medial collateral ligament. And then you, as the examiner, simply apply a valgus stress directly through the joint line from lateral to medial by simultaneously pulling the leg of the examinee away from the midline of the body, while simultaneously applying a valgus stress with your hand. And you've probably done this before, and you can visualize that in your mind.